Okay, so hello and welcome to our Attentive Healthcare Solutions webinar, Making Sense of the 2018 QPP Final Rule. My name is Chelsea Grover and I'm the Marketing Communications Manager for Attentive. I'd like to take a moment to explain the process for today's presentation. First, I'd like to mention that this webinar will be recorded. We'll send out a copy of these slides and recording within the next week. Next, for those of you who aren't familiar with Attentive, I wanted to share a bit of who we are with you. We specialize specifically in next-gen healthcare, and we're passionate about providing solutions for our healthcare provider partners, which in turn help them to improve patient care, enhance the patient experience, and maintain a financially healthy practice. To sum it up, we do everything next-gen. We also have a couple of add-on solutions for next-gen, ChartGuard and Refund Manager. Next, we have a number of upcoming webinars planned that we're pretty excited about. I won't go over them all, but I do want to point out that the next one is going to be the first week in the new year, and it's going to be on the 5.9 8.4 Upgrade Experience, Lessons Learned from Early Adoption. Our goal with this webinar is to help you solve possible challenges before they even occur to minimize your pain points and ensure a successful upgrade. We'll provide best practices for go-live preparation, focusing on testing and training plans. Our objective is to share our expertise and equip you with the information and tools required to conquer this combined upgrade. We hope to see you there. Okay, so back to today's webinar on the 2018 QPP Final Rule. At the end of the presentation, we're going to open the floor up to questions from you. We'll answer all the questions at the end, but you can type them in the questions area of the webinar control panel whenever they occur to you. And finally, for audio clarity purposes, everyone's phone will remain muted throughout the entire webinar. If you experience audio issues, please use the chat box to let us know so we can resolve them. And again, questions may be entered in the questions box. So without further delay, I'd like to introduce our presenters for today. Lindsay Lanning is our Healthcare Compliance Consultant at Attentive, and Cindy Kincaid is Vice President of Client Solutions at Attentive. So Lindsay, the webinar is all yours. Take it away.
Perfect. Thank you, Chelsea. Hi, everyone. Thank you for joining us today for our webinar, Making Sense of the 2018 QPP Final Rule. Just wanted to mention before we get started, we may have some background noise on my end here today. We're actually getting a new roof here in the Columbus office, and I would not be surprised if it sounds like I'm in the middle of a construction site at any point. It seems to have quieted down for now, or if someone falls through the ceiling on me, because that's pretty much what it sounds like at this point. So just bear with me through that. Regardless of my current office conditions, the 2018 Quality Payment Program Final Rule is finally here. On November 2nd, CMS issued the final rule with comment for the second year of this program. And before I really say anything else about it, I'm going to ask you all this. Is anyone on the line feeling a little overwhelmed, honestly a bit concerned about the constant release of final rules that could impact your practice, having any trouble juggling all of them and decipher what's actually important? Since I actually can't see any of you, I'm going to assume almost everyone on the call is shaking their heads yes or showing some form of agreement. I actually saw people raise their hands virtually. Well, I do have two pieces of good news. Number one, you're not alone in feeling this way. And number two, you're attending the right webinar to help you figure this all out. For the next hour, we plan on sorting through all the legislative jargon to find out what actually applies to you. With this constant fluctuation in requirements, we want to make understanding the 2018 program as easy as possible. We understand you don't need to be aware of every intricate detail found in this 1,653-page rule, just those details that specifically affect your practice and its daily operations. So with this webinar, we will first look at the important updates for 2017. And then we're actually going to jump in and analyze both the MIPS and APM tracks and their changes for year two. And lastly, in order to truly keep you, our provider partners, informed, we also thought it was important to give you a brief update on the Medicare Physician Fee Schedule final rule, since it will impact almost every single person on this call in one way, shape, or form. So our first housekeeping item for 2017 MIPS reporting is the hardship exception. Clinicians can now submit a Quality Payment Program Hardship Exception application, and those are available on the Quality Payment Program website. MIPS eligible clinicians and group actually qualify for a reweighting of their Advancing Care Information Performance Category score to 0%. And they can submit a hardship exception application for one of the following reasons: insufficient internet connectivity, extreme and uncontrollable circumstances, lack of control over the availability of certified EHR technology. And these are those same options we saw in previous years with meaningful use hardship exceptions, so those aren't a surprise here. Now, to submit an application, a few things to keep in mind you'll need on hand. You'll need your tax ID number or your TIN, as well as any NPIs you're applying for. You'll have to provide some contact information for the person working on behalf of the group. And then I would go into it knowing which category hardship exception you're actually going to choose. Once it is submitted, you're going to get an email, and these applications are going to be processed on a rolling basis. And then per the final rule that we're about to go over, this deadline was actually extended to December 31st. On the same topic of hardship exceptions, CMS knows that areas affected by recent hurricanes, specifically Hurricanes Harvey, Irma, and Maria, as well as the California wildfires, have experienced devastating disruptions in infrastructure, and clinicians face challenges in submitting data under this new program. So CMS has issued a final rule with an automatic, extreme, and uncontrollable circumstances policy, where clinicians are exempt from the quality, improvement activities, and ACI category without having to actually submit an application. Basically, CMS is trying to lessen your burden by not requiring you to submit an application to reweight those categories. They will be able to automatically identify you. You might be asking how. This policy only applies to you if you're an individual MIPS clinician in an affected area, and that's pulled from actually the PICO system. If you are affected, you'll automatically receive a neutral MIPS payment adjustment unless you submit any data before the deadline, in which case you will be scored. Now, I know where some of your minds may be going at this point. Wait a minute, we don't qualify for a hardship exception. What are we going to do? I thought this was a transition year and we didn't need to fully report. So before anyone asks in our questions box, I will reiterate, it is a transition year. In order to avoid a penalty this year, you just need to get a composite score of 3 points or more. This means you can achieve that in a multitude of ways. Here's actually a graphic from CMS on what you can submit at the bare minimum to avoid a penalty. However, I highly recommend reporting more. Especially if you're a next-gen user, you can submit through the HQM portal. So if you're going to submit one quality measure, why not just select a few more to ensure against a penalty? All right, we're done with our housekeeping items and reminders for 2017 reporting. We are just going to look ahead now strictly at 2018, year 2 of the quality payment program, and really look at what next year will look like for your practices. 2018 is really right around the corner. It's less than 2 weeks away, if you can believe it. And some of these changes will impact your practice right away come January 1st. So I carried this slide forward from our proposed rule presentation to identify some trends and highlights to keep in mind while we go through the final rule. First off is a gradual increase in requirements. CMS plans on gradually increasing requirements to avoid a negative payment adjustment by increasing the composite score threshold from 3 to 15 points. But wait a minute, they made some changes from the proposed rule. Now cost is being counted towards your composite score. And now a full year reporting is required for the quality category. Maybe we should go ahead and revise our word choice and take out that word gradual. There is an increase in payment adjustment, both positive and negative, expected at 5%. That didn't change. After that bullet, I used to have on this slide an increase in reporting flexibility. However, that's actually been removed from the final rule. We will no longer have the option to use different submission methods within a category. But I did get to keep small practice considerations were added. These include things like an increase in the low volume threshold, additional bonus points being available, and the option for an ACI hardship exception. So this really is just a sneak peek at what we will look at here. And for those of you who attended the proposed rule webinar, I just wanted to give you a quick comparison on what to expect with the final rule. It is different than what we expected to come out, and these are changes that don't just affect a small group of providers, but every clinician participating in the QPP. Now that we have an idea of what to expect, let's start by looking at 2018 year 2 changes put forth by the final rule, specifically under the MIPS track. All right, first things first, who participates in MIPS for 2018? Good news here, there's been no changes in the types of clinicians eligible to participate in 2018. These include physicians, PAs, NPs, CNSs, and CRNAs. This list may actually be expanded in 2019. It's still staying constant right now. And then just a reminder, on that right-hand side of the slide is actually a list of those included under the term physician. The exclusion criteria are also the same for 2018, and it includes eligible clinicians new to Medicare, clinicians below the low volume threshold, and clinicians significantly participating in advanced APMs. However, notice the star after low volume threshold. That's because the criteria still remains the same. If you're below this, you are exempt. However, the threshold itself actually changed. Now, to be included in MIPS, an eligible clinician must bill more than $90,000 a year in Medicare Part B charges and provide care for more than 200 Medicare patients a year. With this threshold increase, more clinicians will actually be excluded in 2018. And CMS actually predicts about 35% of Medicare clinicians will fall below this low volume threshold and be excluded. So some of you on the call who may have been surprised you met the threshold in 2017, or who may have used that NPI lookup tool on the QPP website to confirm you were above it, may actually be exempt next year. (2018) reporting options remain the same with the addition of one new option. First, we have individual, where a provider reports data under their NPI and their tax ID number. They will get their own composite score and their own payment adjustment based on their unique NPI-TIN combination. Then you have the option to report as a group. This has to include 2 or more clinicians or multiple NPIs who have reassigned their billing rights to a single TIN, and they receive the same composite score and the same payment adjustment. And lastly, the new option as a virtual group. Virtual groups are made up of solo practitioners and groups of 10 or fewer clinicians who come together virtually, no matter what specialty or location. Now, one very important thing to note for our last 2 options is if clinicians participate as a group, they are assessed as a group across all 4 MIPS performance categories. So you can't report as a group for your quality measures, and then individually for the ACI category. It's an all or nothing approach. With these options and explanations in mind, what we wanted to do is open it up to a poll and see how all of you are planning to report, either as a group, an individual, virtual group, even if you aren't sure yet, or maybe you just aren't participating in the MIPS track and you're participating as an APM. So go ahead and make a selection on your screen here. We're going to go ahead and give it another minute. Responses are coming in, and we really do appreciate your participation. So we get a better understanding of what our provider partners are doing, and this can even help shape some of the resources we release in the future. So still coming in here, just one more minute. All right, it looks like we have a good number of responses here. Now, I personally anticipated group reporting to have the highest number of responses. And not just because I put it as option C, and everyone knows if you don't know the answer, you pick C. However, it looks like my hypothesis was wrong, and most attendees on this call are actually reporting individually. Now, if we look at the provider population participating in MIPS as a whole, the majority has actually decided to report as a group. So let's go ahead and take a look at some reasons why clinicians are choosing to report as a group or as an individual. So with this option in previous years, you had to register and let CMS know ahead of time that you were planning on participating as a group. You no longer have to. Now, there are 2 exceptions with the CAPS, patient surveys, and the CMS web interface, but with that being said, a lot more practices are beginning to look at this option. So some key provisions under group reporting include the entire practice gets the same MIPS score and payment adjustment. You can only select one reporting mechanism per MIPS performance category. So for instance, with the quality category, you have 2 sets of measures you can choose from, CQMs or PQRS measures. You would have to report the same for all of your providers. Now, something that makes group reporting a great option for some is that not every clinician needs to report data for every quality measure, so long as the data completeness requirements are met. So if you have a large multi-specialty practice, this can come in handy. And finally, only one clinician needs to attest to completing an improvement activity for everyone to get credit. Also, along those same lines, if you have a provider you're submitting data for to an outside registry, I'll give IRIS as an example, this can count as bonus points in the ACI category for the whole group, even if not all the providers are sending data. Now, this isn't to say the majority of you on the call who are reporting individually aren't making the right choice. I have many clients who are reporting individually for reasons such as their providers are competitive and they want credit for their composite score. And this is true. There will always be some providers who are actually taking a cut by reporting as a group because they could have had a higher score individually. Or certain providers in their practice fall under the low volume threshold. And if they reported as a group, they would be included and could bring their scores down. Or because half of the providers did better reporting with CQMs and the other half did better reporting with PQRS measures, so they want to be able to choose. In the end, it really does just depend on your specific practice, which option is the best for you. There really is no one-size-fits-all answer here. And our last option is that new reporting option, virtual groups. I mentioned that they need to be made up of solo practitioners or groups of 10 or fewer clinicians. So what else do you need to know? Well, solo practitioners or groups who want to form a virtual group must go through what's called an election process. And this election must occur prior to the beginning of the performance period and cannot be changed once the performance period starts. We're actually in the election period right now. It opened on October 11th and it closes on December 31st for next year. So this is a bit different from just regular group reporting. You would need to register beforehand. Otherwise, in general, policies that apply to groups would apply to virtual groups. They use the same submission mechanisms as groups, and all clinicians within a TIN are part of that virtual group. They are required to aggregate their data for each performance category and will be assessed and scored as a group. Right now, CMS is actually predicting only about 16 virtual groups were formed for 2018. And kind of taking a step back here and evaluating this new reporting option, a pro I see is that communities of small practices can leverage that infrastructure and ride each other's coattails, so to speak. So if your practice only has one doc and you don't have any EHR in place, this is a great way to avoid a penalty. Now, as for the cons, there is a narrow window to organize before 2018. It's already December 20th. There are challenges choosing applicable measures across organizations. And I think the obvious one here, data aggregation and analysis may be pretty complex depending on reporting methods and if different EHR systems are being used. Now, my personal opinion, I don't foresee a lot of next-gen users participating in one of these, nor do I see a huge benefit for providers who are operating on any EHR system successfully. Once you decide how you're going to report, you will need to select your submission methods for each category. There's been really no change in the types of submission mechanisms available in each performance category from 2017. Now, in the proposed rule, CMS, like I said, was going to allow clinicians to use multiple submission methods within a category. However, they have deferred this to 2019. So we will continue using one submission method per category for next year. Now, the performance periods will actually work a bit differently next year. Providers will need to submit advancing care information and improvement activities for 90 days, as most clinicians are this year, but you will need to report quality measures for a full year. CMS stated the reasoning behind this longer reporting period is that they believe a 12-month period will provide more reliable measures and feedback, but honestly, I would stay tuned to see if this is actually finalized. Many healthcare organizations such as MGMA are criticizing this change and speaking out. I can see this being rolled back in a final rule or proposed rule released later next year. And then nothing new here. All of the MIPS category data will need to be submitted by March 31st of the following year. And those MIPS payment adjustments are applied to each claim beginning January 1st, 2020. So on to the composite score. CMS will assign a composite score based on the data submitted under all 4 of the categories in 2018. These categories do have different weights, and therefore some count for more points. You can see quality is the highest at 50 points, ACI is at 25, proven activities at 15, and then cost with the remaining 10. All of these category points are added together to give you that final score, and that MIPS final score is what's compared to the performance threshold and determines if you receive a positive, negative, or neutral payment adjustment. Speaking of payment adjustments, we are aware that that final score is anywhere between 0 to 100. That is, again, like I said, compared to the performance threshold. And if you're above it, you're going to see a bonus, whereas scores below the threshold get a penalty. So for 2018, that performance threshold is set at 15 points. It was previously 3 points. The additional performance threshold stays at 70 points for exceptional performance, and the payment adjustment for the 2020 payment year just goes up 1% to -5 and +5%. Now, two phrases I want to throw out here are budget neutral and exceptional performance. This program is budget neutral, so the bonuses are equivalent to the penalties, or the losers have to pay the winners. However, if you are above that 70-point threshold and considered a high performer, you're actually eligible to receive an additional bonus from 0.5% up to 10% each year through 2026. And this is funded by a completely separate pot of money. So just to take a minute here, now that we know how the scoring thresholds work, what is your MIPS scoring goal for 2018? Really, what are you aiming for? Are you looking at just reporting just enough to avoid a penalty, so just over that 15-point threshold? Are you an overachiever and you're looking to try and get over that exceptional performance threshold, that 70-point threshold? Maybe you did a cost-benefit analysis and you decided you're not even going to participate in MIPS at all. Maybe you're exempt, or maybe you just aren't sure yet. So the responses are pouring in here. We'll give one more minute to answer. I am genuinely curious what the consensus is. If it's meeting the bare minimum or trying for that incentive, or maybe this doesn't really apply to you. I was wrong on my first assumption here, so we'll see. All right, it looks like we have a good number here. We can go ahead and close the poll in 3, 2, 1 if that works. And okay, I was right here. We're looking at about 57% are aiming to go over that exceptional performance threshold. 10% are just looking to report that bare minimum, and then 29% still just aren't sure. So most of the clients that I've been talking to have agreed with you guys that they are reaching over that 70-point threshold. For those of you that are just trying to hit that bare minimum of 10%, maybe this webinar can persuade you to aim a little bit higher here and really ensure against a penalty. But with those goals in mind, let's go ahead and look at the projected MIPS payments. So we know that this is a budget neutral program. We already went over that. But with these low threshold scores of 3 and 15, there probably won't be very many losers. So without a large majority of losers contributing to that pot to pay the winners, we aren't going to see positive payment adjustments actually reach that 4 or 5% mark. It's going to be more like 1 or 2% realistically. But this will only be the case for the first few years. However, if you do choose not to report at all, you will see the full 5% negative payment adjustment for 2018. So I think this table does a great job of breaking down what exactly your MIPS final score means in regards to your payment adjustment. A little bit different this year. It breaks up the negative payment adjustment. So scoring 0 to 3.75 will earn you that max negative payment adjustment. We're earning 3.76 to 14.99 points. You're still going to earn a negative payment adjustment. It'll just be less than that full 5%. And then we know at 15 points it's neutral, and then a positive adjustment up from there. Some interesting stats released by CMS, though, that for 2018 they predict $618 million in incentive payments will actually be dispersed, and that does include the exceptional performers. 74% of clinicians will automatically earn the exceptional bonus, which I think accurately reflects the large majority of you who selected this as your goal on our poll. And then 97% of clinicians will successfully avoid a penalty. I think those are pretty promising statistics moving forward into this year too. Next, providers just need to score 15 points to avoid a payment adjustment, this is still a pretty small threshold. Essentially, it really means that pick your pace mentality is still in place here. So I did want to offer for those 10% who's just trying to avoid a penalty here, some examples of how to achieve 15 points in 2018. It includes reporting all required improvement activities. This would give you exactly 15 points. You can aim to meet the Advancing Care Information base score and then submit one quality measure that meets data completeness. That would actually give you 15.5 points. Again, meeting that Advancing Care Information base score and then submitting one medium weighted improvement activity works as well. Or you could even actually just submit 6 quality measures that meet data completeness criteria. So no matter what your performance is, you're going to get at least a minimum of 3 points per measure, putting you over that 15-point threshold. Now, again, this is very doable for all clinicians to avoid a penalty in 2018. However, we strongly recommend submitting more than the bare minimum to ensure against a negative payment adjustment. If you submit one quality measure and it gets lost in the mix or for some reason doesn't go through, you're going to get an unnecessary penalty that you could have avoided. So we really encourage clinicians to submit more than what is listed if it's possible for you. Now, there have been some new policies added here regarding bonuses and hardships. Let's start with the new opportunities for bonus points. First off is the one that I think will affect a large portion of you on this call, and that's the new small practice bonus. This will adjust the final score of any clinician or group who's a small practice, which is 15 or fewer clinicians, by adding 5 points to the final score. Just a free 5 points for you. Essentially, CMS sat down and they realized small practices have faced the most challenges, and they're hoping that this 5-point bonus will help them meet the MIPS requirements, but also incentivize your participation. So yes, it's almost like CMS is bribing you to participate with these bonus points. Next is the new complex patient bonus. This will apply an adjustment of up to 5 bonus points by adding the average HCC risk score to the final score. So this was only 3 points in the proposed rule. It was bumped up. Basically, they're just trying to support clinicians based on the medical complexity of the patients that you're seeing. And then lastly, the new 2015 CERT bonus. This adds a 10-point bonus for clinicians who use 2015 certified EHR technology only. So you're still allowed to use 2014 CERT or a combination of both, but this bonus is only for providers who use 2015 CERT exclusively. One important thing to note here is that ECs must submit data for at least one MIPS category to be eligible for these bonus points. So let's say just because you're a small practice who's using 2015 CERT, that doesn't mean you automatically get 15 points and you avoided a penalty. You need to actually submit data in order to have the bonus points added. And then finally, looking at the hardship exceptions, starting in 2018, ECs or groups can submit an exception application and have that applied to your quality improvement activities and or cost categories. So what this does, it just basically extends that hardship policy we use for the ACI category to the rest of the performance categories. And these applications are required and they're due December 31st. Now, there are some MIPS special statuses that have been carried over from year 1 of the program. So I mentioned the small practice designation. We also had practices in rural or health professional shortage areas, as well as non-patient facing clinicians. There have been no changes with these. I just wanted to make sure that if you're currently receiving one of these designations, I mentioned them and I didn't leave you hanging, since there are some perks to go with them, which we'll talk about later on. So good news, if you're receiving them now, you'll most likely continue to in 2018. So all that's really left to look at here for next year under MIPS is the specific category changes that have occurred. So we're going to go ahead and start with quality, since it weighs the most towards your final score at 50%. This is actually a decrease by 10%. In 2017, it was worth 60%. Otherwise, CMS will continue to require ECs to report 6 quality measures. This should include 1 outcome or high priority measure. And they're going to evaluate those measures against a benchmark to determine your score of up to 10 points per measure. CMS did actually finalize reporting on at least 60% of the applicable patient encounters. So this is an increase in 10% compared to 2017 for that data completeness threshold. Each measure that meets the data completeness threshold would continue to score a minimum of 3 points. So this is interesting here. Measures that fail that 60% threshold are only going to get 1 point instead of 3 unless you're a small practice. I mentioned this before, but there is a mandatory 12-month reporting period instead of a 90-day option for this category. Otherwise, there are really no scoring changes for measures without a benchmark or that don't meet the case minimum. Overall, the scoring process of comparing the performance to a benchmark that's broken down by deciles hasn't changed here. However, there are some new opportunities for bonus points in this category, besides just our traditional reporting additional high priority and outcome measures. So there's the opportunity to earn an end-to-end electronic reporting bonus of 10%, as well as a new improvement bonus of up to 10% of the quality score. And we will look at both of these a little bit closer in a few slides. In the meantime, just some quick tips for you and your providers to maximize your quality score. Remember, benchmarks for the same measure will vary by reporting mechanism. So you should run both your PQRS and CQM reports and do a benchmark analysis to determine which measure set you should report on. Now, you can only use one and you can't mix measures. So like I said, it's either all 6 CQMs or all 6 PQRS measures. Another way to increase your quality score is reporting a few extra high priority or outcome measures. Something that a lot of people don't really realize is that bonus points for all measures that are reported will increase your score, even if they aren't counted in your top 6. What you want to be aware of is that this is capped at 10%, and any measure you report could be made public for your patients to see on the Physician Compare website. So if you have extra measures over the 6 that are required that are high performing and can count towards bonus, it could be worth it to report, but you don't want to report a low measure because that may be on the Physician Compare website one day. New this year for the quality category is this policy on the life cycle of top-down measures. CMS did finalize it will cap a subset of 6 measures that are going to be considered topped out, and they'll be capped at 7 points. So measures that have been topped out for at least 2 consecutive years will receive up to 7 points, and then they will actually be removed and scored on a 4-year phasing out timeline. So here's the current list of topped out measures that as identified by CMS. Just be aware, if you're planning to report on any of these this year, you may not be eligible to receive the full 10 points at some point in the future. So that means even if you have 100% performance, right now you're getting 10 points, you would only get 7 points. So there's really no room for improvement. And I didn't forget when I said I would provide more details on the other bonus point options for this category. For next-gen users on the call, we really wanted to provide clarification on the end-to-end electronic reporting bonus available to providers. So any CQM submitted using the next-gen HQM is eligible for end-to-end reporting bonus points. However, a PQRS measure is only eligible for an end-to-end bonus if it does not have an aligned CQM, and therefore is on the list you're seeing on the screen. This has been a point of frustration for so many people that I've spoken to, but this, along with the topped-out measures we just went over, are just 2 things you have to consider when selecting your measures and maximizing this category score. So speaking of maximizing your category score, I provided a quick checklist to guide you. First and foremost, determine which submission mechanism, EHR versus registry, will result in a higher composite score. You're going to have to put in the time to run both reports and do a benchmark analysis to really see the benefit. Next, determine which reporting option is best for your practice, group or individual. Again, this is putting in the effort to run both the group and individual reports to compare your scores and decide what's best. Try and avoid reporting on any topped-out measures if possible, since you are capped at 7 and automatically missing out on 3 points. And then lastly, maximize opportunities for bonus points. Maybe reporting CQMs are a better option since you can fully take advantage of the end-to-end electronic reporting. Or maybe PQRS measures allow you to report on more outcome or high priority measures than CQMs, and they're the better pick. There really is a lot to consider under just one category to truly maximize your score, and we definitely understand that. Moving on to the cost category here, this will be counted towards your final score next year, and it'll be weighted at 10%. This is one of the biggest changes from the proposed rule to the final rule that we really weren't expecting here. The Medicare spending per beneficiary and total per capita cost measures are what's included in calculating this performance category score, both of which were actually used in the value modifier program. CMS will use the average of both measures, and if for some reason only one measure can be scored, that measure alone will serve as the category score. But performance on these two measures are compared against performance of other MIPS eligible clinicians during the performance period. So the benchmark isn't based on a previous year. Unfortunately, this means we won't be able to see them in advance like we're used to for the quality category. Now, we aren't going into this completely blind. Feedback reports are still happening. Clients should expect a supplemental QRUR, which will help identify what you would need to do to be ready. There is, however, the opportunity for bonus points in this category, and that's for improvement scoring, which we'll look at next. So this is a new policy in 2018, which actually rewards improvement in performance for MIPS clinicians or groups for a current performance period compared to the prior performance period, and that's just for the cost and quality categories. So under quality, the improvement scoring will be based on the rate of improvement, so the higher improvement results in more points. This improvement is actually measured at the category level, not the measure level, and it's up to 10 percentage points. So CMS has stated it finally wants to reward improvement, not just hitting a standard anymore. Now, some of you may be wondering, does this mean I have to report the same 6 measures every year? And no, you do not have to report the same measures every year. For the quality category, improvement scoring is done at the category level. So instead of tracking improvement on specific measures, CMS is tracking and rewarding improvement on your total category score, no matter what 6 measures you choose to report. So you also have the same improvement scoring opportunity for the cost category. However, for cost, this improvement scoring will be based on statistically significant changes at the measure level. So CMS can actually do this because the measures don't change. This measure level versus category level improvement is a major difference between the two policies. And then with all this information, just keep in mind, none of the performance categories can actually exceed 100%. So this is really only going to be available to you if you have room for improvement. The third category under MIPS is the improvement activities category. This category remains largely the same in 2018. CMS continues to contribute 15% to your MIPS final score. Clinicians are still going to be expected to attest a simple yes attestation to any combination of medium or high weighted activities in order to achieve 40 points. And then the weights are going to remain the same from year 1. CMS did add to the inventory of activities with 112 now available. Some of the ones added that really stuck out to me were the advanced use criteria. We've heard that a lot with the imaging rules coming out. We also have remote patient monitoring opportunities now under this inventory of activities. So essentially, there's been no change to the 90-day reporting period, the scoring policies, the category weights, or the reporting mechanisms, just additional activities to choose from. Small practices and practices in rural areas will actually continue to report no more than 2 activities to achieve the highest score. And there are also ACI category bonus points available. Now, what has changed is PCMH status and scoring. Number 1, CMS finalized the term recognized is equivalent to certified. People were really getting hung up on that differentiation, and that applies to any patient-centered medical home or comparable specialty practice. And then the big change here, 50% of practice sites within a TIN need to be recognized as a PCMH for the TIN to receive full credit in this category. And CMS defined a practice site as the practice address that is available within PICOs. So this is a large change, since if you were a PCMH for 2017, you automatically got full credit. Even if you were the only practice site within your TIN, you got this recognition. And lastly, the final 4th performance category under MIPS, advancing care information, aka meaningful use with the new name and some new rules. First off, as we all know, the ACI category would continue to be weighted at 25%, and ECs and groups are still going to be required to report 4 mandatory base measures. If you're familiar with those, that's your security risk analysis, electronic access, e-prescribing, and health information exchange. You want to do this to avoid a score of 0 and receive 50% towards your base score. You also would continue to select among 7 optional performance measures to earn the additional 50%. And again, you would only be expected to report for a minimum of 90 days. Now, what the agency did do is they finalized an exclusion for the e-prescribing and health information exchange measures. So to qualify for the exclusion, ECs must write fewer than 100 permissible prescriptions or transfer a patient to another setting or refer a patient fewer than 100 times during the performance period. So I don't know how many of you are clapping on your side of the phone line here. These were the exclusions that were in place for both measures under the Meaningful Use Program. CMS received a ton of complaints by eliminating these for 2017 reporting, especially since they're part of the base score, which could mean 0 points for the whole category. Now, if you're asking how are these exclusions going to work, since the HIE measure is actually part of the base score and the performance score, and CMS did confirm that if you claim the exclusion, you're actually going to enable them to fulfill the base score, but you just wouldn't get any points added to your performance score. Also, under the performance score, the requirements for public health reporting have actually been relaxed. MIPS eligible clinicians or groups will earn 10% for reporting to any public health or clinical data registry instead of just an immunization registry. Another policy that was finalized will have a large impact on providers, which we already kind of touched on here, and I'm sure everyone on the call is familiar with, but clinicians are allowed to use 2014 or 2015 certified EHR technology in 2018. One thing to note, there are 2 separate measure sets that are available to choose from, and that's based on your EHR edition. There is that new opportunity to earn a 10% bonus for only using 2015 edition cert, though. Other opportunities to earn bonus points in this category, there are a good amount. There's a 5% bonus available to reporting to an additional registry. Additional improvement activities are eligible for a 10% advancing care information bonus. And then those combined with that possible 10% bonus for 2015 cert, this leaves the clinician with a total bonus score of up to 25% available to them. So taking advantage of this would be huge for this category. Now, there are some provisions that allow providers to qualify for the ACI category to be reweighted, and these are called the special statuses. CMS explained that these statuses are determined by a claims analysis, and you can actually use the QPP lookup tool to figure out if any of these apply to you. So what this does, it'll reweight the advancing care information performance category to 0, and then that 25% gets added to the quality performance category. So there are 2 ways to go about this. You either have an automatic reweighting or reweighting through an approved application. So for automatic reweighting where no application is needed, that's if you're a hospital-based MIPS eligible clinician, which actually has been revised that now you can include place of service code 19. If you're a non-patient facing clinician or an ambulatory surgical center-based MIPS clinician. And then again, we kept with the NPs, PAs, CNSs, and CRNAs. Now, if you actually want to submit an application, there are a few new reasons that you could claim. There's a new hardship exception for clinicians in small practices. There's also the new decertification exception for any clinician whose EHR was decertified. And then those other significant hardship exception categories we mentioned earlier on. And then finally, I said this before, but that new deadline is going to be actually December 31st instead of July 1st. So in my opinion, this just makes sense to do. So since we've gone through all of the MIPS categories, I wanted to select just one special status that I think will affect the most people on this call, and that's the small practice distinction. This is for clinicians in a practice of 15 or fewer providers. First off, CMS will no longer require adaptation on group size. It's going to actually be predetermined using claims data. Some significant areas of relief included in the rule for small practices are, number one, that ability to apply for a hardship and have their ACI category reweighted to 0. That's right. No more meaningful use measures if you choose to submit an application if you want. There's also an extra 5 bonus points added to your final score, just extra boost if you need it. A lower number of improvement activities are required. And then finally, don't forget, CMS is finalizing to continue to award 3 points for any measures in the quality category that don't meet data completeness, whereas everyone else only gets 1. Honestly, this is really just a quick summary slide I put together, just as even to use as a reference next year. We send out this slide deck, and if you're a part of a small practice, you can quickly look here and say, oh yeah, these are the special scoring opportunities I get to take advantage of. So this is really just for your benefit here. Speaking of a quick reference slide, our last one for the MIPS section is how to maximize your ACI score. Now, besides just attending this webinar to review and become familiar with the 2018 changes, there are other ways to maximize the score. First off, you want to check who's exempted from ACI. Use that NPI lookup tool on the QPP website and determine if you're exempt or if you qualify for a special status. If you're not exempt, understand how the measures are actually scored. This ACI category is definitely the most complicated. You have the base score, which is all or nothing, and it's based on 4 measures. And then you have the performance score added to it, where each measure is worth 10 to 20 points. Determine which reporting option is best for your practice. Again, you need to look at group or individual reporting. Consider the implications of group reporting. Any clinician exempt from ACI is now going to be included in that group score. So any special status or being exempt won't matter if you report at the TIN level. Analyze data for a full year and for 90 days to determine which gives you a higher composite score. You have some flexibility here, so use it. Maximize opportunities for bonus points. Like I said, there's numerous ways you can achieve those by submitting improvement activities using CERT, reporting to more than one public health registry. We had to do 2 under meaningful use, so if you kept those up, claim credit. And then consider reporting 2018 measures using 2015 CERT only. And lastly, just make sure to report by March 31st. Don't miss the deadline when you've done all this hard work. All right, we're actually going to go ahead and look at the other track found under the Quality Payment Program, and that's the APM track. And I will go ahead and pass it off to Cindy.
Thank you, Lindsay. Make no mistake, my only purpose in this webinar is to give Lindsay a well-deserved break. She put all the effort into this. We're really going to talk about the APMs and let you know that there's no real changes in the final rule for APMs. They are just extending policies from 2017 in order to continue, as we've been moving along. So as we talk about advanced payment models, our approaches to paying for healthcare that incentivize quality and value. In 2018, they include the MSSP Tracks 2 and 3 and the new Track 1 Plus, Next Generation ACOs, Comprehensive Primary Care Plus, Comprehensive Care Joint Replacement Models, Comprehensive ESRD Care, and the Oncology Care Model. CMS estimates between 185 and 250,000 clinicians will participate in an advanced APM in 2018. Because of this volume, CMS is aware of the need for more models. Currently, there are only 2 APMs accepting new participation in 2018. These are the MSSP Tracks 2 and 3 and the new Track 1 Plus and the Comprehensive Care for Joint Replacement Models. This prompted a statement by SEMA Verna basically stating at this time the only way to avoid NACRA's extensive reporting requirements is for physicians to take on risk to be a part of the advanced alternative payment models, or APMs, which many practices are simply not ready for. Moreover, we have few advanced APM models available and hardly any for specialists. We want to see more models for specialists and models that qualify as advanced APMs under MACRA. We are also in the final stages of developing new voluntary payment bundles. We intend for these to qualify as advanced APMs. We will certainly keep you posted as these changes come about. As we take a look at the 2018 changes, basically we'll start with the requirements reductions. They are going to extend the 8% revenue-based nominal amount standard for an additional 2 years through performance period 2020. By extending the flexibility the nominal risk requirements and increasing the amount of total risk more gradually for advanced APMs, they are fostering growth for these models and encouraging more providers to join. They also removed the 50 clinician cap for round 1 participants in the CPC Plus program. Originally, the medical home standard applied only to APM entities with fewer than 50 clinicians in their parent organization. However, CMS will allow CPC Plus organizations to be exempt from this rule. As we talk about the MIPS APM changes, this is going to wrap up our review of the QPP proposed rule for 2018. We're going to look at MIPS APM changes. The scoring standard is almost like a middle ground of the MIPS and APM tracks. The APM scoring standard offers a special, minimally burdensome way of participating in MIPS for eligible clinicians in APM who do not meet the requirements to become providers and are therefore subject to MIPS, or eligible clinicians who meet the requirements to become partial QP and therefore available to choose whether to participate in MIPS or not. CMS established a fourth quarter snapshot date of December 31st for full TIN APMs, the Medicare Shared Savings Program, for determining which eligible clinicians are participating in a MIPS APM for purposes of the APM scoring standard. This allows participants who joined between September 1st and December 31st of the performance year to benefit from the APM scoring standards instead of fully reporting under MIPS. This is really good news for clinicians. If they're joining an APM in the last quarter of the year, they can do MIPS APM versus full on MIPS. Essentially, by adding this snapshot, they are reducing full exposure to MIPS reporting and just making it easier to participate. We'll do a quick refresher on the APM scoring standard. In the 2017 rule, CMS finalized different scoring weights for ACO models, Medicare Shared Savings Program, and Next Generation ACO models. They were assessed on quality and other MIPS APM, CPC Plus, OCM, ESRD, which had quality weighted to 0. For 2018, CMS finalized to align weighting across all MIPS APMs and assess all MIPS APMs on quality. Basically, they're making it the same. Participants in MIPS APMs who had quality weighted to 0 in 2017 will now be scored under MIPS using the quality measures that they are already required to report on as a condition of their participation in their APM. Basically, CMS assigns the same quality score to each TIN NPI based on APM quality measures. Each TIN in the APM submits individual or group level ACI data, and CMS averages each score to determine one single APM score. Basically, this gives you automatic full credit. So now I'm going to turn this back over to Lindsay to bring it home. I hope you had a nice rest. I did want to give everyone an update. The workers for the roof are back, so I'm hoping we can make it through this webinar, but they are climbing up as we speak. So Lindsay, be prepared.
Great, thank you, Cindy. Yep, I saw them on their way up here. Let's hope they are over your office instead of mine right now. Maybe that'll work out. But I think it's pretty clear after analyzing the 2018 final rule, CMS is at least trying to reduce physician burden and increase participation in these value-based care programs. So let's look at what else they've been working on. One of these is a piece of legislation that I know for a fact will impact all of you on this call, not only with your reimbursement, but other policies and different things that are put in place by this 2018 finalized Medicare physician fee schedule rule. I did just include a few highlights from the final rule that would be most beneficial to cover. First is the mandatory consultation of appropriate use criteria for advanced imaging services. That's been delayed until 2020. The reasoning behind this is to actually allow practitioners more time to focus on and adjust to the quality payment program before beginning participation in an AUC program. So who would have thought they're actually giving us some time to adjust here? Physicians can actually voluntarily participate in the middle half of 2018, but just some flexibility there. Next is MACRA patient relationship HCPCS modifiers. They may be now voluntarily reported beginning January 1st. Basically what happened here in May of 2017, CMS posted a list of patient relationship categories that are going to be required under MACRA. So what this rule did, it actually finalized certain level 2 HCPCS modifiers to be used on claims to indicate these patient relationship categories. The final rule also implements the Medicare Diabetes Prevention Program. This starts April 1st of 2018, and this MDPP expanded model was actually announced in early 2016. This final rule basically just includes additional policies that were necessary to begin furnishing these services. And then lastly, this rule finalized retroactive reductions to the PQRS and value modifier penalties. Now, this may have perked everyone's ears up a bit here. This will affect anyone who submitted PQRS data in 2016. CMS proposed and is finalizing a change to the PQRS policy that requires reporting of 9 measures across 3 domains to only require the reporting of 6 measures with no domain requirement. So I imagine most of you on this call who are interested in learning about the quality payment program were most likely responsible for the value modifier in the PQRS program in previous years as well. So the goal here was to better align with the MIPS data submission requirements for the quality performance category. So what this means, if you only submitted 8 PQRS measures in 2016 because that's all you had data on, or maybe you submitted 9 measures but only over 2 domains, you will no longer be receiving a penalty because the requirements have been lowered. CMS also finalized a reduction in penalties for the 2018 value modifier program. This reduces the automatic downward payment adjustment for not meeting the criteria to avoid a PQRS adjustment from -4% to -2% for groups of 10 or more clinicians, and from -2% to -1% for solo practitioners and groups of 2 to 9 clinicians. It also holds harmless all physician groups and practitioners who met the criteria to avoid the PQRS adjustment from a downward payment adjustment under the value modifier program. So with these policy changes for PQRS and the value modifier, CMS also decided they're not going to report 2018 value modifier data on the Physician Compare website. So everyone is essentially catching a break here. CMS estimates that this change will actually result in approximately $22 million in reduced penalties for physicians. So that's good news for everyone. With this rule, we also see the digital delivery of care impacted in a positive way. Starting with Medicare telehealth services, for 2018, CMS is finalizing the addition of 7 new codes to the list of telehealth services, which you can see listed on the slide. Additionally, CMS is eliminating the required reporting of the telehealth modifier GT on professional claims. So this is a step in the right direction for telemedicine. However, restrictions on geographic location, originating site, and eligible provider site are still in place, and we're working on those. Now looking at Medicare remote patient monitoring, another form of digital care here, we're seeing more and more of this lately. CMS is also finalizing separate payment for CPT code 99091, and this describes certain remote patient monitoring for 2018. So background on this code has actually been around since 2002, but it's now going to be unbundled and be separately reimbursable. Another thing to keep in mind here is that RPM services are less restrictive. They're not subject to those same strict requirements as telehealth. They just have to meet the CPT criteria to be reimbursed. CMS is also finalizing several modifications to the rules for accountable care organizations participating in the Medicare Savings Program. I know we have a lot of clients participating in this, so I just included this slide for your reference. These modifications are really just designed to reduce burden. And then lastly, CMS is finalizing the proposal to revise payment for chronic care management, RHCs and FQHCs, and establish requirements and payments for furnishing any general behavioral health integration services and psychiatric collaborative care model services. So if you are uncertain with where your practice stands, not only with the impact of these legislative changes, but with anything related to the health of your practice, let ITenv help. We can assess your current readiness, provide tailored recommendations, and implement new processes and procedures. Another way we can help is through our MACRA support packages. The time really is now to start preparing for MIPS reporting, even for next year. It's important to start early in order to get the highest reimbursement possible, and we can help you by tailoring the support you need through our macro fundamentals, intermediate, or expert package. So if you are wondering what your next step should be, go ahead and visit us at our website, continue to sign up for our webinars and blog. After each webinar, we actually send out a recording as well as the slide deck for your reference. With this webinar, we're also going to send out a list of our macro packages that were on the previous slide, just for your informational purposes to see how we can support you and how we can help you out with this program. But it looks like we have finally made it to questions, and I still have a voice, so that's a miracle. Thank you all for being on the call today, but I'm going to go ahead and turn it over to Chelsea.
Okay, great. Thank you, Lindsay, and thank you, Cindy. Again, if you have questions, you can type them in the questions area of the webinar control panel. We don't have too many of them, so I think that we're going to be able to get to them all, but feel free to type any if you have them. So first one, can we report as a group for the 2017 if we had not previously registered as a group for this, I'm sorry, let me try that all over again. Can we report as a group for 2017 if we had not previously registered as a group, or is this only for 2018 reporting year?
You are good to go to report as a group. So luckily, not even with 2017, you need to register to report as a group. So you don't have to decide until it's actually time to submit data, and you just have to do that before March 31st of next year.
Thank you, Lindsay. So again, that was March 31st. Next question. Quality category. Do we report on both PQRS and CQM measures, or do we choose one or the other?
You have to choose one or the other. So this idea kind of gets a little bit confusing. The reporting mechanisms available are EHR or registry. If you're choosing to report EHR, you're going to submit your CQM measures. And if you're choosing to report registry, you're choosing to select your PQRS measures. So it's one or the other. You can't do both.
Great, thank you for that clarification. And it looks like this might be our last question. Are there data completeness points in addition to the quality measure score?
There aren't data completeness points in order to actually.
Oh, I'm sorry. I misspoke that, Lindsay. Are the data completeness points in addition to the quality measure score?
So the data completeness is actually just a threshold. So you actually have to have your denominator be over 20 in order to have your measure scored. If it's not over 20, you're just going to receive 3 points. Even if your performance is like 100 points, or excuse me, 100%, you're only going to get 3 points if that denominator is below 20. So that's a threshold that you need to be over.
Thanks, Lindsay. Another question. If a provider is exempt from MIPS per the PQRS website, what programs are they required to attest for 2017?
So if you went on the QPP NPI lookup tool and you typed in the NPI and it said that you were exempt from MIPS, for as far as Medicare EHR Incentive Program goes, you are exempt. You don't need to report any measures and you will not see a penalty. So we were just looking at the Medicare EHR Incentive Program today. If you've ever reported under the Medicaid EHR Incentive Program, that's completely separate. They actually don't have any penalties associated with that. You can still report to get an incentive. But any other kind of value-based care model that we're looking at depends on maybe private payers that you're participating in, things like that.
Okay, great. Thank you, Lindsay. And thank you, everybody, for joining us today. If you have any questions that occur to you after the webinar is over or later in the week, you see Lindsay's information up here. You can also reach out to me when I send out the slides within the next week. Any way you can get a hold of us, we're happy to help, so don't hesitate to ask questions. And thanks for joining us today, and I hope that everybody has a wonderful holiday season.
Thank you, everybody.
Thank you so much.
Bye-bye.